Dear friends and colleagues, welcome to the 54th edition of the 4D, which stands for Diabetes Discussion in Details and a dialogue with an expert on diabetes. Today, India has close to 101 million patients with diabetes, and our aim is to make India a care capital of diabetes management. And hence, we have today chosen the discussion on the problems which the patients of diabetes have today. And that's what today is a point of discussion. And we know that the patients of diabetes have too many comorbid conditions, and how to manage this is what is the discussion today. Because besides these diabetes problems, many of these patients are unaware of their complications also, and therefore, to dive deep into the subject of the diabetes care, we have today a very talented speaker, Dr. Srinivasa Vishnu Vardhana,
Thank you, sir.
who is the consultant physician at the Medicover Hospital and at the Vizag, and who did his MD medicine from the Andhra Medical College at Vizag, and is also interested into the critical care management, and he did a lot of work during the COVID time. He managed very critically ill patients and could give them a lease of life during his involvement in patients of COVID management in the intensive care unit. He also has been treating patients of malaria, encephalitis, tuberculosis, to name few of them, and he has a tremendous academic career to tell us about the details about the problems associated with diabetes in our country. So I'll turn over to Dr. Vishnuvardhan to give his deliberation on the care of diabetes in this country. Over to you, sir.
Thank you, sir. Dr. Vijay, sir, it's a great honor to be having a kind introduction by you. So, yes, you were telling, so we all know that diabetes incidence is increasing day by day. We are seeing many of the cases, like even young people are having who doesn't have comorbid conditions earlier, but unfortunately, because of the various lifestyle activities in recent days, they are landing up in diabetes, unfortunately. And even many of the adult patients or elderly patients who are in remote areas are unfortunately aware of the symptoms of diabetes, likewise the complications that may get because of diabetes, and unfortunately land up in emergency or casualty with various problems. So it is a burden on the clinicians like us and the diabetologists to identify the people who are suffering with diabetes, who are not having the symptoms yet but having high sugars. But then we have to clearly identify them and then treat them with a critical point of view to prevent the complications. So today we'll discuss about the problems associated with diabetes care in India. So we all know, right from the identification of diabetes to even bringing the sugars under control, to identifying the complications and then managing the diabetes over length of time. So all these are critical things that we have to focus on. So we'll see how we are going to do this. So when we come to our Indian setup, there are certain problems that we identify because India has a very huge population, and it has a variety of population wherein some people are having affluent societies and some people have very low economical status. So any of the given conditions, we have to see that the patient is benefited with whatever management we provide, so that the patient can lead a better life. So it's always a huge challenge when we talk about India. So managing diabetes and its complications, it's a huge challenge owing to several problems, including first is a lack of awareness about the symptoms or even the complications among the population. And then diagnosis and access to treatment for diabetes, especially in remote areas. Yeah, as I was telling, so in India is mainly a constitution of various villages, like plenty of villages. And unfortunately, um, unfortunately, many of them does not have the idea what is diabetes, at what age can a person be affected with diabetes, and what symptoms can be attributed to diabetes, and what complications can happen at what stage of diabetes. So we have to provide education, we have to create some information and pass on the information through whichever way possible so that it reaches ultimately in every corner of our country. One more aspect that I was telling is the economic disparities in our healthcare system. So we don't have a uniform healthcare system all around our country. Some people do have the benefit of some insurance companies or some insurance from the government agencies, but then some does not have that. But nevertheless, we have to see that every person who is affected with diabetes can be managed and should be managed with whatever management we can provide. And next point is scarcity of qualified health personnel. Today, when we see that there are plenty of doctors, but then most of them are mainly concentrated in either urban areas or semi urban, but not mainly in the village areas. So, there is a lack of personnel specifically in the village areas and in the semi urban areas as well. Added to that, even the healthcare staff. So, even the healthcare staff, like sisters, nurses, who can manage simple things like giving insulin, even those personnel are insufficient in various areas. So we can't actually address this issue unless it is taken up by the government or some other companies. But then we have to finally make sure that whoever the person is attending to the patients should be qualified enough to understand various drugs or various methods that we provide for treatment and the complications or the side effects that might arise. So, next point is the financial constraints. So, even after prescribing some medication, it is not guaranteed that the patient will continue the medication because of some financial issues. As I was telling, many of Indians are working hand to mouth, and so they might find it difficult to meet the expenses that are required for managing this diabetes or the complications that might arise because of diabetes. So, even that point should be kept in mind while we are prescribing whatever medication. And we have to see that the sugars are under control, but the expenses are also under control. And then comes the social barriers. So the social barriers are different types. For example, some people might feel like having diabetes is like something that they should be ashamed of. So they won't even speak of the symptoms or they won't even inform the same to their relation or to even the physicians. So unless we take proactive steps and ask them about the history or the specific symptoms and do some investigations, we can't even bring out the diagnosis. So, put together, all of these issues significantly contribute to delayed presentation and misdiagnosis, which further increases the existing burden of diabetes. So, if we can see in this picture, we see that the distribution of direct cost in diabetes care is distributed among various aspects. So it could be the disposable or even the hospitalization cost or even the doctor's visit or the monitoring and lab tests or anti-diabetic drugs and other drugs. So it is very common to see people having the diabetes presenting with various complications over a period of a lifetime. Diabetic ketoacidosis, or even simple diabetic UTI. Like patients having diabetes might land up frequently with urinary tract infections, and unfortunately, major complications can arise because of diabetes, like heart failure, or even diabetic kidney disease, or even cerebrovascular accident or stroke. So diabetic sensory neuropathy. So all this can happen, even diabetic retinopathy. So the cost associated with managing these complications will also increase. So we have to keep in mind about various cost factors that might arise, and we have to see at any point the diabetes under control so that we can prevent these unnecessary burden, not just on the patient but even on the government. So we could identify some barriers that are related to management of diabetes. So we'll specifically categorize them into two um, two categories. First thing is patient related barriers. The other one is medical profession related barriers. Identifying these barriers to diabetes management is very much crucial because it improves the quality of diabetes care, which includes the improvement of metabolic control and diabetes self management. So, when we talk about the patient related barriers, first and foremost, as I was telling, is lack of awareness, lack of symptoms, lack of awareness of the symptoms, and poor motivation, and denying risk, because some people they don't even accept what could happen if diabetes is not controlled, if the sugars are not under control. So it all depends on the way we communicate with them. And other barrier is the stress, fear, and confusion. Many of the patients we see who are having diabetes are afraid of taking insulin. Whenever we start insulin because diabetes is not under control, they straight away reject it. They always ask for some oral medication. So they have this stress or fear associated with taking insulin every day. So that could be eliminated just by way of communicating with them. And then we also have to inform them what advantages do we get because of taking insulin. Coming to next barrier is the immediate benefits not seen. So the patient will definitely ask the clinician, so what benefits do I get and within what period of time? They don't clearly understand the major complications like heart failure or even brain stroke that might arise after few years when the sugars are not under control. Unfortunately, they don't have that concept of visualizing the future. Since we clinicians identify or treat many cases and we know the various complications and the burden associated with it, we can clearly talk about it. We'll have the concept about it. But unfortunately, these patients they don't have that concept unless any of the family members was already having diabetes, suffering with those complications, and if the person is going through managing all of them. So one more barrier is lack of family and social support. And the other one is lack of trust in doctors. Because these days, there are few patients who always comment that why should I take this? Why should I take that? So they go through various online media or various online articles, and then they come to us and they inform us what medication we have to write for them. So that is because of lack of trust in doctors. So even this can be prevented by way of communication. And then one more barrier is lack of adherence to recommended guidelines. So there could be various factors for non-adherence or non-compliance. Either it could be self-confidence or overconfidence that the diabetes is already cured, so I need not take the medication, or even financial issues like the person might not afford the treatment. So that could be one more reason. So these are patient-related barriers. So when we come to other category, which is medical profession related barriers, what could be those? We'll discuss. First is medical training focused on acute care. So sometimes what happens is the training that is being given to medical professionals sometimes is concentrated to acute care, which is not entirely reasonable, but then it could happen. So we should also focus on managing chronic care. So treatment of acute diseases more rewarding to doctors. So what we see is whenever we identify a case of acute MI, and we attend to the case immediately, we can see the immediate relief in pain and immediate concept of saving the life. Likewise, attending to a person who is having appendicitis. So, all these cases, what happens is the patient is saved immediately. So, it gives some sort of positive feedback to the clinician as well. But then they might not identify the same, or with some cases like managing diabetes and its complications over lengthy period of time, but that could be understood and then taken care of. So next barrier is even nurses find acute illness treatment more rewarding and better paying. So when we talk about these health staff like nurses, we have to identify which staff is having more knowledge and which staff nurse is very much capable of attending to patients and taking good care, and we have to give some positive reinforcement to them. At the same time, we also identify who are working just for the sake of payment, and we have to try to modify their the way of attending to the patients. Coming to the next medical profession related barrier is the cost of having a team for diabetes management. So when we are talking about diabetes management, it is not just giving medication and the patient continues and there is nothing else. Sometimes what happens is there could be other divisions or other departments that could be involved with diabetes. For example, if the patient has neuropathy, sensory neuropathy or diabetic neuropathy, the patient might develop foot ulcer. So the podiatrist is required over there. So it basically we require a specific team to attend the diabetes patients. So unfortunately, many of the facilities might not have this team, but it is advisable to have one. And the next barrier is lack of trained paramedics. So as I was telling, some health staff or staff nurses might not be aware of various types of insulin or the duration of the insulin or various insulins. So it all depends on the way we provide training or we educate them. So whenever possible, we have to conduct training workshops to these paramedics as well, so that they are up to date with the way of providing management or treatment from their side. So coming to the therapeutic strategies. So we all know there are plenty of therapeutic strategies when we talk about managing diabetes. So, of them, the most critical or the most important one is the novel medication therapy. Likewise, another important thing is early initiation of combination therapy. So, when we talk about the first one, that is novel medication therapy, so even before starting the medication, we always have to educate the patient. We always have to talk with them about the diet that they're taking and what should be avoided and what should be included in the diet, and the exercise that they should do every day or at least every week, a few hours a week. So these are critical even before starting the medications, because without these, whatever medications we give might not even accurately correct the sugar levels. It is always advisable to discuss first diet and exercise and then proceed to medications. So what medications do we have? So we all know first and foremost is the metformin that we have. So it was invented long back, many years, many decades back. And then we also know that since many years we also have insulin. And since past few decades, what happened is there is a tremendous improvement or inventions in diabetic medications. Of them, which are very helpful to us, our first category is DPP-4 inhibitors. The other one is SGLT2 inhibitors, and the other one is GLP-1 receptor agonists. So these class of medications have their own specific mechanism of actions, and they also have specific advantages to that class. Like if we take specifically the GLP-1 receptor agonist, not only it reduces the sugars, but it also reduces the body weight. Likewise, if we talk about the SGLT2 inhibitors, not only it reduces the sugar, but it also take care or reduces the heart failure instance. It also reduces the cerebrovascular accidents, reduces the diabetic kidney disease, or even microalbuminuria. So likewise, there are plenty of advantages or pleomorphic benefits because of SGLT2 inhibitors usage. So if I talk about the early initiation of combination therapy, which is very crucial because even before the patient can identify the symptoms, already the diabetes has started its way of damaging the, either it could be microvascular complication or even the macrovascular complications. This early combination therapy, it's an approach to achieving glycemic goals earlier and delaying the deterioration of glycemic control, and with possible better preservation of beta cell function. For example, metformin along with SGLT2 inhibitors provides a combination of early efficacy and reduced risk of hypoglycemia. Also reduces the weight and also take care of BP, and also reduces CV events and reduces renal failure. So these advantages are there when we start a person who is having diabetes on a combination therapy. So, what other possible solutions do we have when we are talking about management of diabetes? First one is patient education and empowerment. So, since the beginning of the topic, I was saying that education is very important. So, this is what I was telling about. So, these education and empowerment steps are very important because they assure good control of the sugars, and also they will give information about what complications can arise so that they'll be very much prepared. However, the facility and adequate manpower for these are not available even in major cities. So, priority must be given to creating awareness among the public and also to patient education. And the next important thing is the telemedicine. So, during the past decade, we have seen how telemedicine has evolved and how it is improving various people who are in remote areas in, getting a consultation or even getting treatment via online. So, telemedicine has proved to be very successful, innovative method. So, it can be a strategy for closer monitoring and intervention to achieve not only better sugar control or metabolic control, but also to help in the global care of individuals with concomitant chronic diseases. So, over the last decade, several studies have addressed the feasibility and efficacy of telemedicine strategies in the management of diabetes patients. So, wherever possible and whenever possible, we all have to ensure that the patient will be able to connect to us through at least some way of telemedicine so that we can follow up on him, so that we can have an immediate issue that can be resolved or at least attended online, so that the patient will have an idea what could be done.
Very, very amazing lecture. And you covered many aspects of diabetes care in this country. There are
Right.
plenty of questions that have come because of the interest that you generated with your talk. And the
Right.
first question is, what are your thoughts on India being labeled as the diabetes capital of the world? What do you think about it?
Right, sir. So initially, we never had these many patients who are suffering with diabetes. So what happened is urbanization is the word that I would like to use here. So as the people were having the access to junk food, or the way of living or the lifestyle that the people have developed over this past few decades, getting addicted to mobile phones, or even not having the concept of doing exercise, physical exercise. So all these, and put together with some professions like software or even call center jobs. So all these things, or even person who are in government setup, who doesn't have much of the mobility to do some routine movements in a daycare setting. So because of this lack of movements and the availability of junk food, and because of the unhealthy lifestyle, so many of the cases have started because of these reasons only. So this was not the case if we talk like at least 20 years back. But then we are seeing now plenty of cases are rising. The incidence is continuously rising, and it is projected to hit record numbers within few decades. And even the COVID has also pushed many of the persons, many of the people who were in pre-diabetic stage to diabetic stage.
Yeah,
So
I think yeah, yeah, I think you're right. The best evidence is the latest ICMR data
right,
in 2023, which said that the incidence of diabetes has come to 101 million, which was
right,
about 70 million about a few years ago,
right,
just 4 years ago. In 4 years, there's an increased incidence of diabetes by 44%. Look at the
correct,
jump of the incidence of diabetes. And what is interesting is that if you look at various states, the southern part of the India, especially if you see Goa, which is highest number of diabetics, so it's 26.4%, followed by Puducherry, which is 26%, and Kerala, which is about 25.5%. And what is very interesting is there are 136 million of pre-diabetics, which is going to become diabetic. With this huge number, I think what has become is the India has become a diabetes capital. Now, what we to need is to convert into diabetes care capital. Our
correct,
idea is to convert into care capital, and that's why I think this question is important from that point of view. That how do we manage these problems that we have? And to go further, there's one more question on diet. The diet is a major factor in the diabetes management. So, are there any therapeutic factors as an adjunct to the diabetes diet, especially from reference to Indian diets?
right. So when we talk about typically our South Indian diet, what happens is there is a plenty consumption of rice, so which is nothing but carbohydrate. So every household in southern India, the main staple food is rice. And some cases, what happens is the person will consume rice on like daily 3 times, which is a huge amount. So that all contributes to first is obesity, and then even non-alcoholic fatty liver disease, NASH, eventually prediabetes, and then diabetes. So cutting down on the carbohydrates is very much crucial in preventing diabetes. So likewise, junk food, as I was telling. So if we can attend to these factors which are modifiable by way of communicating or providing information to at-risk individuals, like for example, if we start the education right with college people, or even people who are just now started working, like in their early 20s, maybe then they will have some positive outcome out of this education, and the incidence also might come down in the future. So that is
I
my
think,
answer.
yeah, I think you're right. It all started in 1965, and it is because of the Green Revolution by
Right.
Swaminathan, where the incidence of diabetes prior to 65 was just 2%.
Mm,
After the Green Revolution, the incidence of diabetes jumped up to almost 8 to 9%. So
right.
that's increase in the rise of the diabetes is because of the Green Revolution. So people started growing a lot of grains, and
Mm,
with that, the carb content of the diet increased. There's a good publication in Diabetes Care which looked at the consumption of rice in this country. As you mentioned rightly, it is close to 650 grams per day, as opposed to what is recommended is less than 150 grams. So that much of huge carbohydrate load is what is going to cause these problems. In fact, a very interesting article in Lancet 2017, which looked at the Pure study, which said in the consumption of those who have carbohydrate excess, the incidence of cardiovascular disease increased by 26% compared to those who consume fat. We used to
mm,
all the time blame fat, saying that the fat causes all the disease of cardiovascular disease. But in fact, it is the carbohydrate, which is a very important macronutrient in our diet, which has the increased incidence of cardiovascular disease. And this was a very interesting paper. And this paper has maximum likes because it showed for the first time that we need to rewrite the guidelines on diet as the important contributor for diabetes. So that's why I feel as you rightly mentioned, the carb content of the diet has gone very high, and
Yes.
that is the major culprit for causing the incidence explosion of the diabetes in this country. Okay, let's carry on further. And we have been monitoring our patients of diabetes using the conventional methods of
Right.
either fasting or a prandial sugar or a A1C. But the Western countries have adopted the time in range and CGM as the methodology to monitor the patients of diabetes. So, what are the problems that India has that we still have these older methods of monitoring our patients of diabetes compared to the Western countries? What do you think are the possible reasons why we still resort to the older methods of monitoring our patients?
Right. So, as you have correctly mentioned, there are plenty of ways which can be utilized to check on the sugar control. First and foremost is the A1C levels, and as you were telling, the time in range, and also the usage of the CGM machine to see that the sugars are under control in any given day. But then those things like CGM or even time in range to check the time in range, money is involved. Uh, that is what we Indians are typically, affected with or have issue with. So unfortunately, even the people who are affordable or even can afford for that CGM machines or monitors also are not willing to do. And in any given case, one thing that will definitely help us or is like a backup to us is the A1C level. So, nonetheless, like at least one thing that we can always rely on is the A1C. So, at least if we are able to check the A1C once in every 3 month period, and if it is under control, along with a regular checkup of fasting and PPPS, so I think these should be enough, like in any society, like even in low socioeconomic society as well.
Yeah, I think in 2021, we had a meeting of the experts of diabetologists this country and whether we can adopt the Western policy of using time in range and the CGM method of evaluating the patients of diabetes. And this was a very brainstorming discussion. I was also part of it. And what was decided that it is difficult in this country because there is a diverse diet, a lot of cultural problems, and also religious practices that we have. Certain religion has a practice of fasting for 3 months, 1 month, 21 days, and so many things. So, because of this diverse nature, the patient centric care, which is very important aspect of the CGM, which we can't still make it possible in this country. And therefore, we have got conveniently using these A1Cs and fasting and post lunch sugar effectively. I think we still have to work on it as how soon we can adopt those policies, and we need to have a lot of groundwork. As far as
Right,
the cost factor is concerned, we have today in some short while we are going to land on the moon. So India is sending a Chandrayaan, and
right,
India can afford that. I think even TIR should not be a difficult issue, and therefore I think as the more the expert people put in their inputs and they understand the intricacies of the diabetes management in this country, maybe we can have the patient-centric care because for pregnancy, there are different time in range. For elderly patients, a different time in range. For young
lot of
patients, different. So there are a lot of things we have to work on it, and then only we can adopt that policy. Till that time, I think we'll have to resort to use the fasting and the prandial sugar. All right. Now, do you think that despite of increasing numbers of people, there's a still lack of awareness regarding the diabetes and related comorbid condition? How do we understand this issue? That despite
so
of so many numbers you mentioned, we have these problems of lack of awareness.
So now we have plenty of various outlets like the media and all, where we can attain the information whenever we like. So, but unfortunately, what happens is the patient should confide in the article that he's reading or the source from which he's getting the information. So it is not like the patient is going to believe, or the person is going to believe whatever he is going to read across the media, or listen in the media, or visualize in the media. So it all comes down to the person's belief whether he's accepting what he's learning or not. And unfortunately, what happens is some people are so adamant that they don't even accept that they are affected with diabetes, and they don't even continue taking the medication. So I would say, whenever possible, like whenever the person is coming to our clinic, or even through billboards or whatever, if at all we are able to provide information, it is always advisable to give at least some small tips of information, or some basics about diabetes symptoms or the complications that might arise of it. So that would definitely help the people, at least to an extent. So that is my views.
Yeah, I think there was a national study which looked at the lack of awareness of diabetes in this country. This study enrolled about 1,200 patients, and these patients were studied carefully. And what was noticed was that amongst these educated people, which are more than 1,200, 84% of the patient did not know about dyslipidemia, 65% of the patient did not know about hypertension, 90% of the patient did not know about kidney disease, and 96% of the patient did not know about the stroke. And the peripheral vascular disease was not known to close to 35% of the patient. Imagine the depth of the ignorance amongst the people.
Right.
And that's probably because there are a lot of myths about diabetes and the education. And I think you will use very good word to begin with in your discussion is empowerment. So unless until you empower the patient to understand what the disease is, till that time he would not realize that these are the hidden dangers of diabetes management. And it's a huge, huge, huge problem. One has to realize, to believe it, and to take action on that. I think for that, the empowerment is the correct word. I think
Yes.
based on that, only the next question that what is the most effective way to ensure proper patient education uh, about diabetes? What is the best, according to you, what is the best way?
So if you ask me, sir, I would say face-to-face discussion, not just with the patient, but again, the person who is taking care of the patient. For example, if the patient is female, then it would definitely help if we include the husband as well in the discussion. Likewise, if the person is an elderly male, we have to include the children or even the grandchildren or whoever is taking care. So, if we are able to provide information collectively to that particular family who has come for consultation, maybe then definitely it will pass through all the people, or at least few people, and then it will be again help them to have a discussion, or even ask few more questions and gain more information from us. So I would say face to face discussion is always the best option. There could be other ways, like providing them some brochures, providing them some articles or videos, so all these. But then if we have face to face discussion, whatever doubts they may get or whatever questions they may ask, it could be cleared instantly.
Yeah, I think you're right. The education forms a very important backbone tiding over this crisis. That reminds me of a very important quote by a Chinese philosopher, Confucius, and also was echoed by the US statesman Franklin Roosevelt. And what he said was that if you tell me, I'll forget. If you teach me, I may remember. If you involve me, I will understand. So
Right.
here the involvement of the patient should be there. And what we used to do during our diabetes camps is to make a lot of programs where the patient themselves used to act. For example, we had made a skit on diabetes where we said that Munna Bhai MBBS was a skit with diabetes specialization. And
Right.
then a lot of patients themselves would act on that and
Mm.
people would attend that. It used to be very, very interesting program. Then we
Right.
had made a musical program also where we had a lot of songs from the Hindi movies in which we converted some changes in that and made them from another patient only sing them so that the patients were involved in that. So the involvement is very important. Unless until you involve the patient in that activity actively, I think this will remain as a mirage because unless until patient takes that part in the diabetes management, it is difficult. This is based on exactly what was done in the alcohol anonymous meetings, where people alcoholics would come together and discuss about their problems and how to get overcome the problems of the addiction, and they help each other to understand. So that's exactly what I think is a need of our today we need to adopt. All
Yes.
right. There are a lot of interesting questions. I think the first you also mentioned about the acute management and the chronic management, and you yourself are the one who treat a lot of patients in the ICU, and you take care of a lot of critically ill patients. Is it true that treatment of acute illness is more rewarding than the chronic diseases?
I would not specifically categorize and talk about it, but I would look at it as a comprehensive healthcare. So, for me, if you ask me, acute care setting is not more satisfying, or the chronic care setting is less satisfying. So, I would specifically say whenever the patient has come to me with some specific complaint, if that complaint is resolved and if he's happy going home, so that would give me satisfaction. And I would be least bothered whether it is acute care or even chronic care. Because, in my view, both of them are important and crucial, not just for the person or the patient, but for the entire family. If he's he could be a breadwinner, or he could be the sole employing or earning person. So it makes a lot of difference. So any care setting should be really important.
Yeah, I think so because the acute care setting, the patient comes to you running. He has a
Right,
problem. So if he approaches you, usually the etiology and diagnosis are easy to manage, and
right,
recovery is usually a rule.
right,
Where the chronic care setting comes insidiously. So it takes longer time for the patient to realize there's something going wrong.
right.
And then there are multiple factors, multiple etiological factors to cause that disease. Plus,
Right.
their hereditary is also an important factor, which has to be considered. Plus, the
Mm,
factors like lifestyle, pollution,
mm,
habits. You mentioned a lot of habits. You mentioned about alcohol, tobacco,
mm.
all that you mentioned in your talk. All those are going to contribute. To
Yeah,
redress them becomes difficult. So,
right,
therefore, in the chronic care setting, the cure is hardly there. It's only control, and the patient wants cure. That's why they fall prey for all these quacks who promise them a lot of cure things, and they say I will cure this problem, I'll cure your disease. So therefore they fall prey for that, which is
correct,
not true actually. And they don't realize this there's a difference between the acute care setting and the chronic care setting. And all the medical education, there's hardly any attention paid to the chronic care setting. Nobody teaches so much about diabetes in undergraduate, even for the postgraduate, unless you
mm,
do specialization in diabetes. So that's
correct.
the reason why I feel that the chronic care setting is slightly difficult to manage compared to the acute care setting. Two more questions. Again, they are very interesting. Then this is, what are your thoughts on the telemedicine strategy for managing diabetes, especially in the rural areas of India, to which you really alluded to? What is your thoughts on that? How is it going to help us?
So, telemedicine was actually invented, I think, even 2 decades back. But then the implementation is not that fast in our Indian setup. But specifically during the COVID time, so there was a boom, or almost every doctor was talking to their patients through telemedicine only. So even I was attending to my patients after completing my rounds. So I was coming in the evening and I was starting this video conversations via phone, and I was having almost like 20 consultations in a day. And it was like, I would say I was not comfortable with that, because the way of communication is not clear. Unfortunately, what happens is, first thing is the data connectivity. We might not have the fastest internet connection, or the person who is talking on the other end might not be having a fastest connection or even a good device. First, that could hinder. The second thing is the audio visual capability of the patient might be insufficient, so that could affect. And then whatever words we utter might not be clearly understood by the patient, and we might not even be patient enough to repeat it. So all these factors might come into play, and then the conversation might be, unfortunately, as an unsuccessful one or an incomplete one. But then we always give medication and all. But I would say, if you are having a specific query, then attending via telemedicine is a good thing. But then if you are having an entire consultation through telemedicine, and the lack of examining the case also plays a major role. So put together all these factors, I would say we can fall back to telemedicine whenever there is an emergency, or an emergency advice that we have to deliver. But then it is not helpful in providing complete care. So that is my answer, sir.
Yeah, I think right, because ISRO was the first one to introduce the telemedicine way back in 2001. And that
Mhm.
was the Apollo Hospital from Chennai, which was connecting to some villages in Chittoor district in Andhra Pradesh, the Apollo Rural Hospital. That's how the telemedicine started much earlier, actually. With the COVID, of course, we have been reusing it, and it has really has a lot of problems, as you mentioned. Besides technical problem, there's the issue of privacy, there's the issue
Mhm.
of safety of data, and of
Mhm.
course, the communication also may not be as good because of the lot of technical problems. So I think, but still, we could connect to the patients and could hand over some kind of information and could do hand holding to these patients when they had difficulties in the bad times during the COVID. So that brings me to the last questions of tonight, and that is your specialty itself, where you have been working very hard for so many years, and that was the what all overall impact of the pandemic of COVID on the diabetes care in India.
Right, sir. So if you ask me, like, before COVID, so the number of cases of diabetes were also more, but then people in around 30s was less. But after COVID, what happened is the number of people around 30s or early, like 20s, late 20s or early 30s, has tremendously increased. So again, when the incidence of diabetes starts in these second or third decade, obviously tags along the complications. Either it could be microvascular or macrovascular. So the number of years of the person having this diabetes, which is not under control, would definitely land up in some sort of complication in coming further years. So that is the specific thing that I have observed in the past few years.
Yeah.
Apart from that, I could not see. But one more advantage is we now have plenty of new medications, specifically like GLP-1 receptor agonist, which not only take care of diabetes but also the weight status of the patient. So we have some tremendous innovations recently, even the new age insulins also. So these have these are actually helping in managing diabetes in whichever case that comes to us. So there are advantages as well as disadvantages that I have seen.
I think right, but I feel that it amplified the inequalities in the healthcare and the health outcomes very badly. And
Right.
diabetic patients suffered disproportionately high and they had a higher mortality. In fact,
Right.
there's a study done in Switzerland which
mm,
looked at 50,000 patients who were
mm,
seen during the COVID time who had diabetes. And what they saw was there was a large number of patients who did not follow up. The 25% of the patient dropped that follow up. Then the large number of patients did not do their A1C, they did not do their creatinine, their body weight was not checked up for quite some time. And the elderly patients around the age of 60 years in that study showed that even stopped the insulin injections, stopped the oral drugs, and therefore there are a lot of calamities because of the COVID, because of the pandemic episode. And also there's a new onset of diabetes itself, which was described in 14% of patients because of COVID infection itself. And
mm.
then the huge plethora of the post-COVID syndrome,
Yes.
which affected a large population, and plenty of them lost their taste, plenty of them had a lot of weakness, chest pain,
Mm,
cardiovascular manifestation, atrial fibrillation, problems of vaccination. I think all these created a lot of impact on the human health and their well-being, and therefore it has kept, I mean, it kept a deep scars on the minds of the people about this pandemic. And therefore,
mm,
I think, but only thing, as you said, the good part is we knew what our deficiencies are. Maybe we are well equipped now. We have understood a lot of problems. We understood a lot of immunology. We have restarted learning immunology, which we had almost forgotten after a medical school. So this is some good learning to learn experience, which
mm.
happened because of the pandemic COVID. So thank you, Dr. Vishnu. We had a wonderful discussion for the last 53 minutes. It was very
Thank
absorbing and a lot of new inputs you have really shown us regarding the care that we should do for patients of diabetes. I think your words of wisdom will go a long way in the minds of the people, and they have a lot of learning experience from you. And before we close, I want to ask you a last question. What is your message today, and the one line message for people who are listening to you about
Yes.
this care capital of diabetes?
Eat healthy, do exercise, follow guidelines. That's all.
Very good. Thank you very much, Vishnu, for your
Right.
kind advice to
Thank,
people.
thank
So, eat healthy, exercise, reduce weight,